Okay, everyone, I will get started here. It's absolutely my honor to help present a friend and colleague, Dr. Arielle Sheftall, who will be speaking about a really important topic today on understanding some of the disparities among youth of color and understanding how to do suicide prevention work really well. I will start really briefly by highlighting some of what our team at the Center for Suicide Prevention and Research at Nationwide Children's Hospital have done in collaboration with MindWise Innovations and Signs of Suicide, and then turn it over to the star of this show. And I'll share a bit of good news about her week as well in just a moment. So my name is John Ackerman. I'm a clinical psychologist and suicide prevention clinical manager at Nationwide Children's Hospital in Columbus, Ohio. My work there at Nationwide Children's is primarily focused on supporting youth suicide prevention efforts in schools, communities, and healthcare settings. At Nationwide Children's Hospital, we've heavily invested in identifying different areas in which we can do better in meeting the needs of youth and families who might be at risk for suicide. And we know that suicide is really complex. It's really hard to predict. So we need research to better understand when the needs of youth are high and how we can start to implement universal strategies that don't rely on these simple predictions. We need to make sure that we know where to get suicide prevention resources to individuals who are in need, and we need to understand the context in which these needs are elevated. We need to help make sure that we have support for young people when they're in crisis, and we need to make sure that the adults who are able to respond them know how to best respond. I think for a long time we've relied on specific avenues like healthcare settings or schools to do this, but I think a lot of what Dr. Sheftall will talk about is how some of these spaces can be expanded and how we can meet the needs of individuals better at where they are. So to that end, over the last 6-7 years, our Center for Suicide Prevention Research has partnered with MindWise Innovations to help maximize the impact for their evidence-based signs of suicide programs. And we've already within the schools themselves, we've delivered SOS to about 57,000 students in 180 schools in 22 counties here in Central and Southeast Ohio. So we're really excited about some of that work, and we focused on how we can implement suicide prevention better, how we can make sure these schools can do this in a sustainable way. But we definitely understand that the work isn't done when you have started that implementation process. In partnership with MindWise Innovations, we're really hoping to help reach and impact lots of different communities of different backgrounds, and we can do this in a way that's sustainable. So we're in the process of actually creating a 4th and 5th grade version that will center on developmentally appropriate methods to help prepare youth to meet the all too real mental health crisis that we see in young kids. Some of the research that actually Dr. Sheftall has helped bring to the forefront of our national dialogue. So we want to make sure this is something that can really be a resource, but in a way that's done in a really developmentally appropriate way. And so we're also here to really look at possible gaps in this work. And this really brings me to the reason why we're here today. We'll hear from, really, again, a good friend and colleague, Dr. Arielle Sheftall, about ways to better address the needs of youth of color in this space. As I said before, really, you can't look at this area without her research popping up to the forefront. And I think you're going to be in for a real treat today. Dr. Sheftall is a primary investigator at the Abigail Wexner Research Institute at Nationwide Children's Hospital and faculty of the Center for Suicide Prevention Research and assistant professor of pediatrics, psychiatry, and behavioral health at the Ohio State University College of Medicine. So lots of credentials that are well deserved, and I think what I really want to get to is where I've seen Dr. Sheftall's heart, which is in her research around understanding familial and developmental risk factors for suicidal behavior, to really understand what it is that drives suicide risk so that we can prevent it, so that we can learn different intervention strategies, so that we can do something about it. And to that end, I will embarrass her by congratulating her on her just minted R01 grant award on the effects of parental history of suicidal behavior on middle and late childhood. It's a longitudinal assessment of early markers of suicide risk. This is a big deal. Some of you are researchers will know this. To get an R01 and drive this incredibly impactful work is such a great accomplishment. So I will let you all hear about this incredible work, and also really highlight just the last two major elements. Her work is really spans an incredible continuum of work. We've published some work together on how media can do a better job of reporting on suicide more effectively, that actually won an important research and journalism award, because we know that our media systems can do better about talking about this. And she's also helping us better understand how we can know whether our prevention work is meeting the needs of Black communities and Black youth in particular. So we're going to be doing a lot of work to hear directly from our communities and learn how we can adapt some of the work with the signs of suicide even more effectively. So lots going on. I'm going to turn this over and just thank you for the opportunity to introduce Dr. Arielle Sheftall. I'll turn it over.
Thank you, John, for all of that. I appreciate it so much. And thank you all for being here. It is really an honor to be present and to share some of the knowledge base that I currently have, but also have a dialogue about what exactly we can do as a community, as a team, to actually think about suicide prevention in a different light, and to think about how we can actually do something that's going to make a difference. So without further ado, I'm going to share my slides here. So as indicated, I'm going to talk a little bit about suicidal behavior and how we can implement suicide prevention in communities of color. And just so everyone is aware, I do receive funding from the National Institute of Mental Health and the American Foundation for Suicide Prevention. I have no other conflicts to disclose. And whenever I do a presentation, I always put these phone numbers up because I think they are the most important slide that you will see today. I honestly believe that these numbers can make a difference and can save lives. And as Victor was speaking earlier today, well, this morning, the National Suicide Prevention Lifeline is going to be changing to 988, which I think is even going to be more impactful. But I always encourage folks to just have these numbers available in their phones because you never know when you'll need them. You never know, person, friend, on the whatever, family member. It's always a necessity to just have these around just in case. And you never know when you'll need them. So please feel free to take a picture, put them in your phone if you don't already have them, because again, it is the most important slide you will see today. So in terms of the objectives, what I'm planning to do is give you some brief epidemiology about youth suicidal behavior, and then talk primarily about Black youth suicide and the research that I've done in that arena, and then give you guys some insight on what I think potentially could be opportunities for suicide prevention with Black youth. So definitions, I'm hoping that majority of us know what these are, but I'm going to be saying these words consistently throughout the presentation. So I just want to make sure we're all on the same page. So when I state suicide, that is the death of an individual by an act that was explicit or had inferred intent to die. With suicide attempt, it's a non-fatal injurious behavior with, again, you have to have that stated or inferred intent to die present. And then suicidal ideation is just thoughts of ending one's life. And then when we talk about suicidal behaviors, that encompasses all of these terms. So it's kind of like the umbrella term that we use in the field to talk about suicide, suicide attempt, and suicidal ideation. Another term that you may hear is non-suicidal self-injury. So that is when an individual will hurt themselves on purpose without the intent to die. And usually it's because they want to relieve some suffering, some pain that they're experiencing, emotional pain. And they believe that physically harming themselves will actually help with that. So just so you guys are aware, that is not under the umbrella of suicidal behaviors, but it has been associated with suicidal behavior. So this right here just shows you the rates of suicide deaths among 10 to 19-year-olds overall from 1997 to 2019. And what we found is that from 1997 to about 2007, we saw this decrease happen, the significant decrease. Everybody in the field was extremely excited, and it was 28%. So we thought we were doing a good service. We thought we were moving in the right direction. However, when you look at the most recent data, unfortunately, we've noticed that that has not been the case. So from 2007 to 2019, we actually experienced a 68% increase in youth suicide, and this increase has occurred in both males and females. And in 2019, it was the 10th leading cause of death for all age groups. However, for 10 to 19-year-olds, it was actually the second leading cause of death. And it accounted for more than 2,700 deaths in 2019 alone. So definitely a problem, a concern that we should be taking into consideration. And when you think about that number, 2744, it's actually more deaths that accounted for by suicide than 7 leading causes of death. So again, major public health concern, something that needs to be addressed. And then, as many of you may already know, but if not, that's okay. More males do die by suicide than females. About 75% of those are males versus females, so about 3 times more. However, with some of the recent work that we've done with myself and a colleague, Donna Roosh, we've found that this disparity within the rates of males versus females is actually closing. So what we found is that for females in this younger age group is actually having a larger increase in their suicide deaths compared to the older age group. However, the gap in between is actually closing slowly and can be seen starting around 2007. So when you think about methods of suicide death, what you'll see here is that unfortunately more males will die by firearms than females, and the majority of suicides are that happen in females usually occur by suffocation or hanging. And this data is from CDC as well for 10 to 19-year-olds over this 5-year range. And then some of the other work that I've really focused my energies on is this younger age group, because unfortunately, what we've found is that majority of research is really focused in on adolescence, early adulthood, later adulthood, but not really on this younger age range. And unfortunately, we have seen some significant increases in this younger age range. So let me just orient you to the slide here. On the bottom here are the year, and then this is the suicide rate per 100,000. And as you can see, it's still very slow. I'm sorry, very low. And this is the number of deaths. So the number of deaths are actually the red bars, and the rate is the blue line here. And then from 2090 to 2019, we actually have experienced a 139% increase in suicide deaths in this 5 to 12-year-old age range. And then when you look at self-harm behavior, so this information also comes from the CDC, for this 5 to 12-year-old age range from 2001 to 2018, we have experienced a 454% increase in self-harm behavior among these youth. So that's suicide attempts, non-suicidal self-injury, and these are cases seen in the emergency rooms only. What are we missing is my question, and how much could this increase if we were to look at youth at home that do not present to the emergency department themselves? So another slide just to show you about this age range, this preteen age range, and moving forward. This is a slide that shows age cohorts, so birth cohorts specifically. And what you'll see is the blue line's 1995, so kids 1995 to 2000, and so forth. And what you'll see is that for the 1995 birth cohort, the suicide rate became um, relevant, so to speak, I guess, which is not a good term, but was present around 9 years of age. So about 9.5 to be kind of exact. And then for our 2010 birth cohort, what you'll see here is that it's actually starting, the suicide rate is actually present around 8 years of age. So the younger we're getting in terms of our birth cohort, the younger the age of suicide that we're seeing. So unfortunately, what we're finding is that the rate is increasing and the age of actual suicide is actually happening younger compared to older age groups or older birth cohorts. So that's just a general overview of the epidemiology of youth suicide. And now I really want to give you guys some insight on Black youth suicide and suicidal behavior. And unfortunately, in 2019, it was the third leading cause of death for Black youth 5 to 19 years of age, and it accounted for approximately 323 deaths. And just to give you some background, in 2009, suicide actually accounted for 208 deaths. So a significant increase in suicide deaths occurred from 2009 to 2019. It was a 55% increase to be exact. I forgot that was on the slide. Please forgive me. So I have been very, very honored to be a part of this research since the beginning. Well, not the very, very beginning, but since the first report that we had, which came out in 2015 with my colleague, Dr. Jeffrey Bridge, who is our center director, where he actually received a phone call from a media source and asked specifically if he knew anything about youth suicide in this younger age range because a child had recently died who was 8 years of age by suicide. And to be quite honest, at that time, we weren't doing any of the research in this age range. And there wasn't really a point of focus or a person that we could actually point that media source to. So he decided to actually look at the data and to see what was actually occurring in this 5 to 11-year-old age range. And then I came out with a paper that kind of followed up that paper to kind of think about what were those circumstances that could have happened prior to suicide death in this age range 5 to 11 versus 12 to 14-year-olds. And what we found is that there were differences for this younger age range versus the older age range. But the one difference that I found that wasn't a significant difference is that the kids, 12 to 14-year-olds, and the 5 to 11-year-olds actually disclosed suicide behavior or suicidal thoughts early, well, not early on, but at the same rate. So 30% of the kids actually indicated that they wanted to die or that they were going to kill themselves. And it did not matter which age group they were in. So I think that is very telling. And that indicates that no matter how many times we have a child that discloses suicide or suicidal behavior to us, we have to take it seriously because we never ever know what that chance is going to be or what that disclosure is going to lead to. So, again, taking everything as seriously as we can. And then there was a report that Dr. Michael Lindsay and I, Dr. Michael Lindsay conducted in 2017. And in 2017, there was a report examining racial discrimination and how that could potentially be a risk factor for suicidal behavior in Black youth. And then in 2018, Dr. Jeffrey Bridge, myself, and other colleagues came out with this specific paper. And what we found is that for Black youth, 5 to 12 years of age, they were 2 times more likely to die by suicide than their white counterparts. And then it actually flipped at age 13, where they were less likely to die by suicide. And as you can imagine, again, we ran the data, we ran the data, we ran the data just to make sure that we were reporting things correctly. And unfortunately, what we found was true, that Black youth 5 to 12 years of age were 2 times more likely to die by suicide than their white counterparts. And this was for both males and females. And then with a paper that I conducted with Dr. Michael Lindsay, we looked at suicide attempts and suicidal ideation. And what we looked at was Black youth compared to white non-Hispanic youth and all other racial and ethnic backgrounds. And what we found is that for Black youth specifically from 1991 to 2017, they had a significant increase in the self-reported survey that they had completed, which is the Youth Risk Behavior Survey. They had a 73% increase in the attempts that they reported. And then there's also a question on that survey that asks about suicide attempts that required medical attention. And what you can see here is that for Black youth, there was a 120% increase in that rate for Black youth specifically. So all of this information led to the Ring the Alarm report that came out that was actually spearheaded by Congresswoman Bonnie Watson Coleman. And I was honored to be on the task force and to actually participate in writing this report and getting it out there to the world, so to speak. And what we did is we talked about the current research that was present at that time, and then we had recommendations about what research should be done. We had recommendations about policies that should be enacted and practices in clinical care. And it's been an honor to serve still to this day on this task force. And we just recently met, and Bonnie Watson Coleman, Congresswoman Bonnie Watson Coleman, wants to actually start another initiative very soon that is focused on Black girls because of one of the reports that we actually had come out just recently. And I'm going to share that data with you as well. So one of the things that I have done and I've tried to really do in my own research is to kind of put a spotlight on Black youth suicide and not always compare it to other groups of youth from different racial and ethnic backgrounds. And I have had a lot of what's the word I'm looking for? Pullback or pushback, so to speak, in that arena. But I really do think it's important for us to understand the problem within the group itself in order to think about what interventions are going to be appropriate, what are the protective factors that are going to be relevant, what are the risk factors that we need to really hone in on. So I had a paper that came out in JCAP and at the end of 2021. And it really just focused on Black youth only. And what I wanted to do is look at the data and figure out, are there any increases that we're seeing by age group and also by sex? Then also, what were those potential risk factors that happened prior to suicide death by age group and by sex? So this first slide shows you what the trends were that we found. So for 5 to 11-year-olds, we found that there was an annual percent change of 3.9%. So basically, from each year, we saw a significant increase occurring for 5 to 11-year-old Black youth. And they were the group that had the second highest annual percent change. For the 12 to 14-year-old group, we found that they had a 2.9% annual percent change. And then for the 15 to 17-year-old group, they were the ones that saw the largest increase. So 4.9% annual percent change that occurred over this period of time. So 15 to 17-year-olds, followed by 5 to 11-year-olds, and then the 12 to 14-year-olds. But again, all increased over this period of time. And then for males and females, the blue line is males and the gray line here is females. And what you can see here is that males tended to have a higher rate of suicide deaths than females. However, when you look at the annual percent change, females actually had the higher change presented. They actually had a annual percentage change of 6.6%, which is about almost double, well, a little bit over double what was presented for the males, which was 2.8%. And I think this report, unfortunately, does highlight that Black girls are increasing at a significantly higher percentage than our Black males, although both are increasing. But again, that gap is starting to close between males and females. So, in terms of precipitating circumstances or risk factors that happen prior to suicide death, in Black youth specifically, when we looked at the 5 to 11-year-olds and the 12 to 14-year-olds, we found a lot of similarities amongst those groups. Majority of unfortunately died in their own home. Majority had a family problem or a school problem that happened prior to their death. And the injury happened within 24 hours prior to, after an argument had occurred. But there were some differences that we did find. So for 5 to 11-year-olds, we did find that if those youth were diagnosed with a mental health concern, they were more likely to be diagnosed with ADHD. And then for our 12 to 14-year-old age group, those Black girls were more likely to die by suicide than their male counterparts, and when compared to any other group. So Black females 12 to 14 years of age were more likely to die by suicide than the 5 to 11-year-old girls or the 15 to 17-year-old girls. When looking at the 15 to 17-year-olds, we found risk factors that were pretty developmentally appropriate. Some, well, they had more boyfriend and girlfriend problems than the 5 to 11-year-old group or the 12 to 14-year-old group. There was a recent criminal or legal problem that had happened prior to suicide death. They were more likely to leave a suicide note. And then if they were diagnosed with a mental health concern, they were more likely to be diagnosed with depression or dysthymia. And also substance use concerns were present for this older age range as well. When we looked at girls versus boys, we found that girls, unfortunately, were more likely to experience a relationship problem or crisis prior to their death. They died within 24 hours of an argument. They also were more likely to have physical health concerns to be reported as something that they were coping with. And we always think about how mental health can exacerbate or be found in our physical health as well. And I think that's potentially an opportunity for us to do some intervention or to do some screening in primary care facilities or in specialized clinics where kids may be seen on a regular basis. So again, another point of intervention might be present for girls specifically, but also for others as well. They were more likely to have a history of suicidal thoughts, plans, and attempts. They were also more likely to be in mental health services, have a history of mental health services, and also to have a mental health concern. And if they were diagnosed with a mental health concern or disorder, it was most likely depression, dysthymia, or anxiety. And then for our Black boys, they were more likely to have a recent criminal or legal problem. Again, a potential intervention could be surrounding that system. I know, unfortunately, with some of my colleagues working with the system, the juvenile justice system can be very challenging. But if presented the right data and you have an advocate in the system, it might be easier than what we think. So I think that is also another point of intervention that could be occurring for our Black youth. And if they were diagnosed with a mental health concern, for the Black boys specifically, it was ADHD. So I think that's a lot of information I just presented. And I know that it seems very grim, but I do want to give you good news. Suicide is absolutely preventable. And I don't say that just to say that. I say that because I mean it. And I think there are ways that we can work together to make it preventable, not only in Black youth, but in other youth, in other groups of color. I think there are ways for us to actually engage and think of outside the box in terms of how to prevent suicidal behavior and suicide in general. So, what do I mean by that? Well, I think first and foremost, we need some research. I hate to say it, but it's very true. We have very, very, very limited research that is presented or that is present in youth of color. It's just unfortunately not been an area of focus. And like Victor said this morning, it was thought that Black youth and Black individuals just didn't die by suicide. So nobody really had that be a focus of their work. Well, unfortunately, we are in a different space now, and we know that that's not true, and that's not the case. And we really need to figure out from a research perspective, how are these culturally relevant risk factors actually playing a role? So discrimination, stereotypes, racism, experiences with these things, how do those actually affect our mental health, affect stigma? Stigma, how does that affect suicidal behavior? We don't understand what those connections are. And unfortunately, we absolutely need to understand what they are in order for us to make a difference. We also need to think about the theories that exist within the field of suicide and suicidal behavior. There are a number of those that do exist, and I know that later on today, Rory O'Connor is going to be talking about a little bit of his theory, and that theory is very, very relevant, but it hasn't been tested primarily in minoritized youth and Black youth, and it's not, again, it's not because we're bad people. It's just because it just hasn't been done, and it needs to be done in order for us to, and to actually figure out if these theories are relevant, and if they are, or if they aren't, what we need to do to make them relevant and adapt them, or do we have to start fresh and think about establishing new theories, and making sure that that drives the research that we are engaged in. Another thing that we need to really understand is this trajectory. So, with Dr. Michael Lindsay's work, our work, we actually found that even though there were increases seen in the attempts and increases seen in the attempts that were actually required medical attention, we didn't see any increases in ideation, which we thought was very odd, to be quite honest, because in our world, you have ideation, so thoughts of suicide, then you potentially will have a plan, maybe not, and then you will attempt suicide or unfortunately die by suicide. So it's kind of this progression, so to speak, that occurs. And for Black youth, it doesn't seem to be the case. And I've actually talked to a number of other individuals that are interested in this work, and they indicate that it's the case as well, that ideation doesn't seem to be present, or we're asking the wrong question. And I think that might be the case, to be quite honest, is that maybe we're asking the question about ideation incorrectly, and youth are not responding to the way that we're asking the question, or they aren't responding because they don't feel like they can. So that's just is going to take some more research, unfortunately, on our end to understand what is this trajectory. Is it different? Is it the same? Or are we asking the right questions to actually make sure we are engaging Black youth specifically, and also getting them the help that they need prior to that behavior actually occurring? And then I think it really boils down to some mixed methods approaches that are really needed. And I'm very, very honored that MindWise was actually willing to come and collaborate with myself, because we actually submitted a grant to look at the Signs of Suicide program for Black youth specifically. And what we had proposed is to actually do a mixed methods approach, where we're talking to individuals in the community, we're talking to individuals that serve Black youth and their families, we're talking to Black youth and their families themselves, and trying to get some insight on, does this program meet all of their needs? If not, what are those needs that we need to meet, and how can we adapt it if necessary? And then we're planning on piloting it as well. And we're hopeful, fingers crossed, that it will come out and will do great things, and we'll actually learn more about the Science of Suicide program itself. And then we can take that information and apply it and potentially make that adaptation and make it relevant for all groups that MindWise is serving. So something coming soon, hopefully in the very near future. And then other opportunities, I think, for prevention. this is just my thoughts, so please forgive me. If there are others, I am more than welcome to hear them. I really, really, really believe it's important for us to engage community organizations. Our and I come from, I'm saying me, I love my community. I am very much involved in my community. I am a part of a church. I'm doing things with my church. I'm engaged with my church. I'm engaged with the youth ministry and the youth pastor. And I think that that's just a great avenue for us to examine and to explore. And this is just one example, faith-based specifically. Dr. Sherry Mullock created the Helping Alleviate Valley Experiences Now, the Haven Project. And, she is in the process of actually testing that and getting some pilot data. She's had the project in her own church for quite some time now, but now is engaging in a multi-site piloting study to really get some insight on what's useful, what do we need to add, and how can we help. And it's really about just giving resources in a space that is trusting and is trustworthy and wanting to help the congregation in all aspects of their lives, not just physical health, with the health fair that happens, but mental health as well, because they're connected and we can't do one without the other. Thinking about school-based, we talked a little bit about signs of suicide. We're going to see if that could be actually either adapted, or if it's doing a great job with Black youth specifically, mazel tov, right? As what my family would say. I grew up Jewish, so please forgive me. But another program to consider is adapted coping with stress course. So this is something that was actually created in DePaul University by Dr. Robinson, where she took Black youth themselves and said, okay, here's the program, coping with stress course. And what do you think works? What do you think doesn't work? What other things do we need to add? And it's all about giving kids tools in order to cope with stressful experiences that they are unfortunately engaging in on a regular basis. And not only that, she has these scenes that the kids have created where a kid goes into a store, a corner store, and they're followed around because they're Black youth. And what does that feel like, and how does that affect their mental health? And they talk through those things, but these kids created these scenarios in order for it to be relevant for them and their peers. And she's actually implementing that program now and hoping that we can get some good information from that coming soon. And then I really do believe gatekeeper training programs are really something that we can do in the community that might be very, very helpful. Educating those that are engaged with the population that we're trying to serve is really important. So, thinking about after school programs, the barbershops and beauty salons, thinking about urban leagues, Boys and Girls Club, which is something that John Ackerman and I had a chance to do last year, where we actually educated their staff on the signs of suicide and what those looked like and what to do if they actually found a child that had these signs. And then it just gave them more insight. And we try to do it on a overall in terms of getting staff from the very top all the way to those that were actually engaged with the youth on a regular basis. So it was a really good program, and I think we're going to try to keep on going with that program and implement it in other arenas. And then My Brother's Keeper program is something that's done through some urban leagues that is specific for Black youth, Black male youth. And then Peel Them Layers Back is actually something that's being done in Cleveland by Archie Green, and he is a rapper, and he actually talks about mental health very openly and has four programs right now that are, I think two of them or three of them are youth specific, where he takes the hip hop culture and actually engages youth. And at the end of one of the programs, they actually write a song about mental health and how that is so eye-opening for those youth to have that experience, and just to be able to lay it out there, and to be able to actually show that you can talk about mental health, you can sing about mental health, you can rap about mental health and not feel less than. So really breaking that stigma down and doing that through hip hop culture is something that he's really been engaged in, which I think is so cool. Um, so last but not least, I wanted to show you guys this picture because I really feel like this is suicide prevention for me in a nutshell, especially when it comes to Black youth. This is a bridge that's actually in Magdalay, India, and it is considered one of the wettest, no, actually the wettest place in the entire world. They actually get, I think it was, yeah, 32 to 45 feet of rain on average a year, which is crazy sauce. But that's how much rain they get. And back in the day, they had to get from one, spot to the other. And what they found is that they couldn't do it because when the floods came, and they just couldn't do it. Well, someone decided, why don't we use the roots of these trees to actually make bridges? So that's what ended up happening. So this is actually roots of the tree that have actually been built into bridges and has been done for generations and generations so that when the floods come, when the rain comes, they can still get from one place to the other. So I think of us as being kind of like the roots of this tree. We have to start somewhere, right? And we have to twirl ourselves around and work with each other and collaborate with each other in order to make change. And it's going to take time. It's not going to come overnight. But I think it's really important for us to consider that if we work together, everybody's going to bring something to the table. And, I'm going to bring the research piece, you're going to bring the intervention piece, you're going to bring the community piece, and it's all going to work together to actually save lives. And that's what it boils down to. That's really what it boils down to, that this has to be a collaboration with community, with families, with youth pastors, with others to really, really, really make a difference and make the path present. So, with that, I just want to thank my team because I could not do this work without them. It's hard work, but we still keep on doing it because we believe in it. And also just give my contact information in case you are interested. That's our website. I think it's not as up to date as we would like it to be, but it's an ongoing process. And then also my email address. So thank you so much.
Thank you so much, Dr. Sheftall. That was so interesting. We do have a handful of questions
Okay.
in the Q&A, so I'm gonna pick one now. Let's see. So we've gotten a lot of questions actually have come in about the rise of internet and social media use. Have you seen any correlations there?
So I think the one, and I get this question all the time, so you are not the only one to ask this question. I absolutely think it's an important question to ask and an important question to actually research. So we know that there's increase in, social media, an increase in bad things on the internet. Everybody has access, right? It seems like my 9-year-old, unfortunately, we limit his access completely, so he doesn't have any of that stuff going on. But it's true. Like we know that kids are out there and unfortunately can see a lot of these things, a lot of bad things online. And we do know that there is a correlation to suicidal behavior between social media, but it's not a cause. So I definitely want to clarify that. We don't know what all the causes are. And suicide itself is so multifaceted, and it's not just one thing that causes suicide to occur. So social media, could it play a role? Potentially, yes. It is associated with suicidal behavior, but it's definitely not the main cause.
Thank you. So you also discussed the lack of research for Black youth. Another area where research is lacking is in transgender or non-binary youth and those with disabilities. How can we address intersectionality in research?
No, that is absolutely 100% true. It's so bad. I hate to say this, but it's so bad. And these are groups of youth that are at very high risk for suicide and suicidal behavior. And I think, unfortunately, back in the day, these groups, they still are. They're marginalized, right? And they weren't seen. They still by some are seen as less than. And the research just has not been presented in this light. There are some that are doing some Black youth with transgender LGBTQ plus youth. I have seen some literature when I do my searches, but again, super limited, super limited. And then when you think about even looking at youth that, excuse me, there was actually a group of youth that John did signs of suicide with that, again, just wasn't looked at, but youth that have hearing impairments or that are deaf, that's also a huge risk to suicidal thoughts and behaviors. And there's a different community or culture that is present there as well. And again, just research is non-existent in that arena. So I think what it all boils down to is doing the best that you can to get these like baby pilots going, so to see these little pilot studies, and to actually do these presentations and make it known that there is risk present in these groups of youth, and being an advocate for these groups. And even though NIMH or other organizations may not be interested in funding this research right now, if you make enough noise, I guarantee it will be something that they're interested in. And I know that sounds really bad, but that's truly the case. Like Black youth suicide wasn't on the radar, but we started making noise. We started working with the Congresswoman and her team and the Black Caucus and getting this information out there and making that noise. And finally, we had a RFA is what they call it, for Black youth specifically. But that's been probably the only one that I've seen ever since. So again, making the noise, keep it going, advocating for these groups so that we can see difference and make a difference.
Thank you. I love that. Such a strong emphasis on advocacy. And I know there's a lot of strong advocates in the audience today who that really speaks to. So another question we had are around parents and families. Have you seen a connection to suicidal behavior in parents and families with youth? And how could family interventions help?
Yeah, so my research, my other line of research looks at parental history of suicidal behavior. So that is something that I very much focus in on, because it is a group of youth that is at very high risk for suicidal behavior themselves. To be exact, they're about 4 to 6 times more likely to actually engage in suicidal behavior if you have a parental history, and you do it really young. So the average age of youth that attempt suicide is around probably like 12-ish years of age, and that is decreasing. Don't get me wrong, you will see younger youth that do attempt suicide. But for those that have a parental history, that actually occurs around 11 on average. So you're seeing it at a younger age. And even in my own sample, I'm seeing it at a younger age. So we have about 10% of my kids have attempted suicide already. And I have kids 6 to 9 years old in my study. So that is devastating, number one. Number two, it means that we have to start super early when it comes to intervention. That is a clear sign for me for this specific group of youth. Absolutely. I think that we can do it. Family interventions, I think, are going to be really, really important, to be quite honest. And one of the ones that I've been kind of looking into a little bit is Incredible Years, which is really primarily focused in on kids that have externalizing behaviors, but it's actually a parent training program where you train your parents how to regulate their own emotions, and then also how to be models for their kids to regulate their own emotions. And what we found in the research that I've written up so far is that emotion regulation is so dysregulated in these kids that have a parental history, and then their parents are dysregulated as well. So that's just one way of potentially thinking about intervening with these groups and of youth specifically.
Thank you. I know we have some fans of Incredible Years
Yeah.
in the audience today. Have you seen any research into treatment methods that would be more effective with Black youth than with other groups?
Unfortunately, I don't think the research is out there. I really don't. There is there are some programs that are specific to cultural identity. So we have the Brothers of Ujima and the Sisters of Naya, which is they're programs that have been done in schools and I think also community organizations, but I have to check that to be specific. But what they found is that when they have youth that go through these programs, it's all about cultural identity. So identifying with who you are and seeing that as not a bad thing. I'm a Black female. I see myself as a Black female, and these are all of what my ancestors saw. And encouraging youth to actually have a really strong racial identity has actually been associated with better mental health. So those are some programs that haven't been specifically applied to suicide prevention methodology, but again, might be opportunities for us to think about in terms of maybe racial identity, increasing racial identity amongst youth might actually give us a barrier to some of these suicidal thoughts and behaviors that we're seeing, or decrease in suicidal thoughts and behaviors that we're seeing.
Yeah,
Yeah.
we're getting a lot of questions. I know this is sparking a lot for folks.
Yes.
I really like this question. So, what do you say to people? What can we say to people who say that really young kids, young people don't know what they're doing? They didn't mean it. Cognitively, they can't understand
They
the
didn't mean it.
permanency of death, right? What do we say to
Yeah.
that?
Oh yeah, I get that all the time, right? Because I work with kids 6 to 11 years of age, so they didn't really mean that. Well, did they? Like I whenever I have asked a child, whenever I've interviewed a child, and we do this, we ask the parent about the kid, and then we ask the kid about the kid, and we do that separately. Whenever I ask a kid, have you ever had thoughts about suicide? Have you ever had thoughts about killing yourself? No. Like very, very easy to answer for my no's. But then when I get my yeses, they absolutely understand what I'm asking them. They know if they've had thoughts about killing themselves. And I think it's a disservice to really not give kids credit. Kids are really smart, honestly, very smart. And we don't give them enough credit. And if a child is actually having a thought about hurting themselves or about killing themselves, what does it matter? What does it matter? Why not have that conversation, see where they're at? Why not just engage with that kid, be a listening ear, get them the help that they need if they are currently having those thoughts? But why not? Why not? Please, please don't brush it under the rug and think that it's a false or think that it's something that we shouldn't take seriously. Because again, in that one study, I found 30% of our kids, 5 to 11 years of age, said they wanted to die, said they wanted to kill themselves, and nobody took them seriously. 30%. That's a lot of kids that we could have actually saved if we just would have taken that one time, that 50th time, the 500th time serious. Every single time should be taken serious, no matter what. That's just my thoughts.
Do you have guidance for non-Black clinicians and teachers who are supporting Black youth in addressing suicidal behavior?
I think honesty is like the best policy. And I know that's that little silly saying that we say, but just knowing that you aren't going to understand where that kid is coming from, and that's okay. That is okay. We are not expecting you to know everything about Black culture, Black hip hop culture, R&B thing. We don't want you to study and look like you are coming off as ingenuine, like not genuous, right? There are going to be things that you just don't know, and that's okay. And just being open and honest with the family and with the kid up front and saying, you know what, I am a white, or I am a Hispanic, or I am an Asian, or I am a whatever way you identify person. And I'm not going to know what you're experiencing, and I'm not going to understand the ins and outs, but I'm here to listen. And maybe I'll have something that might be relevant for you to hold on to, but we can work together to do that. And I think that's the important part. I think in terms of therapy, and for therapy to be relevant and for it to actually work, I think it has to be a working relationship, right? You learn things from that person and that person learns things from you. And just being open and honest and having that dialogue can really go a long, long way.
Collaboration, that honesty, it's so
Mhm.
powerful.
Absolutely. And I'm not a clinician, just FYI. So, but I like to say that up front. I am not a clinician, but I do think that that would go a really far way. I mean, if I were to think about myself, I am a biracial woman, and I have, my Black side, I have my Jewish side, and like that's all me. That's me. That's who I am. And me finding a clinician that's those things, what's the likelihood of that actually happening, right? But being able to say, you know what, Arielle, I don't know where you are or where, like, what your background is, or I don't understand that. I don't, but I'm willing to listen and willing to help as best as I can. And just being, again, honest and open about it.
Thank you.
Yeah.
I think we have time for one more question. And this sort of ties into our general conference topic. So I think it's a nice one to leave off with. So do we have appropriate pathways to help young kids? They're not necessarily going to call a helpline. What are today's pathways for kids? And what do you think the future should hold for supporting our young kids?
No, that's a really great question. I think you're right. Not to my knowledge. Maybe they do, but 6 to 11-year-olds, well, that's not true. Some of the older kids will have a cell phone, right? And be able to, text the chat line or the crisis line. But our 6-year-olds, probably not, right? And even as young as 5-year-olds, unfortunately, are dying by suicide. So what can we do? Well, I think it's really important to create this prevention bubble around our kids. And that's my term that I've been using lately. But educating the teachers, educating the after school program, educating the parents, educating the caregivers, educating all those people that are surrounding that child about what are those risks, what are the signs that you should be looking for, when it comes to depression, when it comes to anxiety, when it comes to um, you know suicidal thoughts. What are those things that you should be looking for? And not only that, what you should do when you see those signs. What are the steps that you should actually take? Because I think that's the most anxiety provoking thing. If you see the sign and you don't know what to do, then you're probably going to be a deer in headlights, right? And not know where to go from here. So I think it's really, really important to not only educate on the signs, but also educate on the process and what are the steps that need to be taken after those signs are actually indicated or found to be present. So I think it's really important to just think about what are those avenues that we can take with kids, specifically in this age range, to create this prevention bubble around them and to ensure that as many people as they're interacting with, that they know what to do and they know what the signs are. And even like thinking about their siblings, right? Not only just because, unfortunately, with that paper, we found that a lot of the time, the younger kids were more likely to actually disclose to their siblings than to disclose to a parent or to a friend. So making sure that those siblings are involved in that process as well. And again, you're going to talk to a kid different than you talk to a parent, right? So making sure that you're talking to them in the most appropriate developmental level so that everybody is getting the information necessary so that they can actually act and make sure that that life is saved.
Gosh, I love that term, prevention bubble. I think there's going to be a lot of us who are going to be using that term from this for a long time. And so many of us are working to make those prevention bubbles for kids and families. So thank you so much for this incredible and important conversation. I think many of us, I hope you have a chance to see the chat. There's been so much engagement and interest and
Mm.
appreciation for this profound work. So we really appreciate your time today and for answering all these extra questions as well.
Absolutely, absolutely. Well, thank you so much for having me, and I am so thankful and so honored to be here. Thank you.
Thank you.